on to the next slide, sir. Whenever you want the next slide.
Fine. Okay. Good evening, everybody. I am Dr. Bharath, Kshatri, urologist. On behalf of...
Hello, sir, just one.
Yeah.
Sir, I'll give you the countdown first and then you.
Yeah. Okay. So everything is there. Okay.
You just need to say next slide, please.
Okay. No, this should not be anything, right?
Yes. So we'll take one good laptop for this kind of things.
Okay, this is more.
Hello.
Yes. Yeah.
Yes. So sir, it's 3, 2.
Yeah.
1.
My view
Sir,
is all right. View is
yes,
fine.
it's perfect. Yes, it's perfect. So over to you, sir.
Good evening, everybody. On behalf of Lupin, I thank Dr. Mr. Anand and Tanvir for arranging this program. Today, I am going to be there with you for a short period to discuss benign prostatic hyperplasia. So at this busy hours of you all, maybe I'll give some tips which are going to be helpful for you. Next slide, please. These are the Nobel Prize winners in urology. And then next slide, please. So modern view of BPH is benign prostatic hyperplasia is maybe associated with the clinical presence of bothersome LUTS, anatomic enlargement of the prostate, and pathophysiological changes. Next. So this is a combination where the of give rise to LUTS. So in the terminology, BPH is the histological diagnosis. Usually it is called benign prostatic hypertrophy. BPE is the enlargement due to the benign growth. There is benign prostatic enlargement. BPO is the urodynamically prone bladder outlet obstruction. So this is the terminology which we will be frequently discussing during this talk. Next slide. Lower urinary tract symptoms. These are the bothersome symptoms that occur in an aged man who is around 50, and then the symptoms are attributable to the lower urinary tract dysfunction. Either they are problems with storing the urine or of the voiding. So maybe associated with BPH, BPE, or BPO, but not exclusive to this. So these symptoms, LUTS is a very vague symptom. It can be due to anything, and for that reason, just LUTS is not benign prostatic hypertrophy. So you have to rule out other things before you decide on the treatment. Yeah. Next slide. Differential diagnosis. That's what I was saying. So if there is a LUTS symptoms, then you have to be worried about to rule out before you going on for a specific treatment. It could be urethral stricture. It could be just a bladder neck contracture, bladder stones, urinary tract infection, interstitial cystitis, and the most important, you may be missing a carcinoma of prostate. So even a carcinoma of prostate will present like benign prostatic hypertrophy. So be careful when you are treating a case of a benign enlargement or LUTS patient to rule out all this before you start on your treatment. Next slide, please. So this old paradigm is small prostate, thin bladder wall, enlarged prostate, thick bladder wall. So these are old scenario, but now we have a cystoscopy, we have a CT, we have a MRI. So before going on for any management, you will know what exactly we are dealing with. Yeah, next. Yeah. Subsequent paradigm will be normal prostate, enlarged prostate, small prostate with alpha receptors. So there are wide number of receptors are distributed in the lower urinary tract. They are more so in the prostatic capsule, and they are also at the trigone region and also distributed in the floor of the bladder. Next. So a brain and spinal column also, there is a lot of intricity between the sensitivity, the motor activity, and the neurogenic activity, and the detrusor muscle activity. So these all can have an effect on the storage of the urine and voiding of the urine. So let us not go into detail about this today. We'll go ahead with the symptomatology and the further management of BPH. Next slide, please. So prevalence is more than, at age 50, it is 50% of the public will have prevalence. By 80s, 80% of the men will, by 79 years, they will have prostatic symptoms. In India, the prevalence of BPH was reported in hospital and community was to the tune of around 10%. Next slide. So going to the pathophysiology of BPH, it is androgen dependent. It is related to male hormone. So prostate hyperplasia occurs because of the variation in the hormones, and that will, and aging, that will lead to bladder outlet obstruction. Non-BPH causes also can be a cause for the obstruction. Then it will have a detrusor response, detrusor aging effects, neurogenic disease, primary bladder disease. All these will lead to lower urinary tract symptoms, which can be added by polyuria also. So pathophysiology of benign prostatic hyperplasia, epithelial and stromal cell proliferation. This is the histopathological changes. We will have cellular growth factors, altered androgenic environment, genetic disposition, reduced NO levels, increased. These are all biochemical changes that can lead on to the ultimate enlargement of prostate. There could be autonomic overactivity, inflammation, reduced blood perfusion due to atherosclerosis and ischemia. These are all hypotheses, but exact cause for occurrence of benign prostatic hyperplasia, other than aging and testosterone, nothing much is known. Yeah. Next slide, please. So there are AUA guidelines for BPH, like this: basic management of LUTS, recommended tests, detailed management of LUTS, recommended tests, and optional tests are there. In this, most important is relevant medical history, assessment of LUTS, severity and bothersome IPSS scoring, physical examination including distal rectal examination, urine analysis, and never forget to get one PSA done before starting prostatic anti-prostatic treatment. So we have also validated questionnaires and then frequency volume chart. Optional tests are Uroflow and residual management by sonography. Next slide, please. So physical examination, you have to assess whether it is a spongy and then non-indurated, rubbery in consistency with all edges felt, just maybe the increased size. Any alteration in the feel should suspect of you should suspect asymmetric or frank nodules. You should suspect prostatic CA, and do also a neurological examination, so that by starting treatment, your results are guaranteed. Because if it is a neurogenic bladder, he may not succeed in giving relief to the patient. Yeah. Next slide. BPH assessment by uroflowmetry. There are most of the flow rate meters record the voiding time, flow time, time to peak flow rate, average flow. In this, most important is peak flow rate and average flow rate. So they should be more than 10 to 12. This is helpful even in the assessment of the treatment. It's a simple test that can be done at the clinic side. Yeah. Next slide. So Qmax, that is maximum flow rate, should be in a normal person should be more than 15 ml per second. Anything less than this, then you start suspecting bladder outlet obstruction. Next. Uroflowmetry, obstructed flow, but they never reach the peak, but slowly they'll be able to empty. This also is one of the obstructed pattern. Yeah. Next slide. Evaluation will include the clinical examination, physical examination, and then taking the history Then you, looking at the IPSS score, you divide them into watchful waiting, medical therapy, or invasive therapy, like cystoscopy is important, and then followed by surgery. Next slide. In part 2, we have a initial evaluation, distal examination, objective symptom assessment, additional diagnostics test if necessary, like blood urea, serum creatinine, blood test. All these have to be done. And then any other, if you are following for surgery, you have to do all tests for the anesthesia fitness also. Yeah, next one. So goal of therapy for BPH is you must reduce, successful measured by symptom score reduction, bothersome symptoms reduction, quality of life improvement, prostate size either arrest or stop the further growth, increase in peak flow rate, prevention of long-term outcomes, and acceptable adverse events profile. See, this is more important. If you aggressively treat the patient, you may get all the results. But then nowadays, if it is as it is a chronic treatment, there shouldn't be acceptable adverse events for which you have to go for the better and the better drugs. Next. Watchful waiting is for the small IPSS score when there is less than mild symptoms are there, and then that time you can go for a watchful waiting also, because all men will not require a procedure or intervention or surgery. The surgery, the requirement is only for the 10% of the people, and even the medical treatment only we can treat most of the cases of mild and to moderate BPH patients. Next. So AUA guidelines for medical treatment is alpha antagonist alpha blockers, 5-alpha reductase inhibitors, and antimuscarinics. Next slide. Alpha blockers are the best. They are time tested. They are you can avoid so many surgeries for so many people, because they open up the bladder neck and then voiding has improved, and this has given to relief for a lot many people in our present practice. 5-alpha reductase inhibitors are also useful to the extent that they will reduce the size of the prostate, and physical obstruction will be taken care, and this will take some time to act. But then if you add alpha blockers along with alpha reductase inhibitors, 5-alpha reductase inhibitors, in long run, you can definitely take care, you can reduce the dosage, or you can stop also the alpha blockers. Yeah. So antimuscarinics are recommended, but they are having a lot of side effects. So unless it's warranted, we do not put a lot of antimuscarinics during our practice. Yeah. Next slide. Yeah. Next slide. So paradigm shift in management. Okay. There is a combination therapy is also there, where you can start alpha blocker with 5-alpha reductase inhibitors. This will give a better results in long run. And yeah, next slide, please. This is a meta-analysis with the tamsulosin plus dutasteride. You have various combinations. Either you can use finasteride, you can use dutasteride, you can combine it with tamsulosin, you can combine it with alfuzosin, or even silodosin. Yeah, they are safer. Yeah. Next slide. So dutasteride with the tamsulosin is supposed to be the largest. This is the best combination because not many patients are using this combination. Yeah. Next slide, please. Yeah. Silodosin also can be combined with dutasteride. Yeah. Next slide, please. So these are various combinations, and alpha blockers can be combined with the muscarinic receptor antagonists to avoid your some of the severe LUTS symptoms. Next slide, please. Yeah. Next slide, please. Beta 3 agonist mechanism of action. So now of late, you must have seen that we use a lot of beta 3 agonists And mechanism of action, as we all know, one of the significantly used molecule is mirabegron. It has come in a very big way. Even Lupin was they are pioneers in getting this drug and then making people consultants and then public aware of this molecule. And now we are using it abundantly and with very minimal side effects. And this can be combined for treatment of LUTS due to benign prostatic hypertrophy. Use of beta-3 in men with moderate to even the severe LUTS, it can be used who have storage symptoms. So they should not, earlier we had thought that they will cause a retention. It is, yeah. So LUTS who mainly have storage symptoms. Yeah. Systemic review of combination drug therapy for non-neurogenic lower tract symptoms. There are systematic the reviews. They all say that safety of the drug which can be combined in lower urinary tract symptoms due to BPH. Sexual BPH and sexual dysfunction. Treatments may cause sexual dysfunction, erectile dysfunction, altered ejaculation. Treatment should be tailored according to quality of life and sexual function issues, because not many people complain of dry ejaculation because there is a retrograde ejaculation. They will have dry shots. So some younger people may complain of this. So they should be told that they will have some changes in their sexual life. Yeah. So effects and safety of Tadalafil monotherapy for lower urinary tract symptoms. Yes, Tadalafil is also used for lower urinary tract symptoms. They give good results, and this can be combined with other medications also. And this will also reduce the dosage of alpha blockers. Yeah. Next slide, please. Surgical treatment, of course, is to TURP is the gold standard benchmark of surgical therapies. Transurethral resection of prostate when patients don't respond to all these medications, and there are indications for surgical treatment, like there is a lot of residual urine, when there are stones are formed, when he is going for a acute urinary retention and chronic retention. Surgical treatment stands the only way for treating benign enlargement of prostate. Yeah. Next slide, please. There are other minimally surgical procedures, but nothing has to test of time. TURP is still the gold standard. We have used prostatic stents, we have used tuna, we have used microtherapy. All these are should be useful in writing the answer paper for the MCS students. But in practice, these only accept laser, which is come up this way, come up in a big way. Other things are for only academic use. Next slide, please. Take-home messages. As I said in the beginning, pathophysiology, it is the aging and the altered hormonal balance which gives rise to BPH. Not all men of LUTS are BPH. There could be other things. Not all BPH are LUTS. Consider combination therapy. Quality of life matters. Thank you for attending. Thank you for the team support. Sorry, there was little delay, and then they have helped me in a right manner. Thank you once again for Roshni and Lupin Pharma for giving me this opportunity to share some of my ideas with you all people. Thank you.
Hello.
Yeah, Roshni, you have cut the...
Yes.
Yeah.
Yes, sir, there are some greetings in the chat box.
Okay, some questions are there?
No, sir.
Okay.
So, can we wait for another 1 to 2 minutes if any question comes?
Pardon? Anything, Roshni?
Hello.
Yeah.
Yes, sir, can we wait for another 1 to 2 minutes if any question comes?
Yeah. I'm here. I'm available. Yeah. Okay. So there are some chats, and then okay. Thank you. I have to send to everyone.
Hello.
Yes, Roshni. Yeah.
Yes, sir. Sir, one question from in the chat.
Okay. I can hear them.
Hello. There is one
Yes.
question in the chat box,
Yeah.
which is, sir, how to identify differences between BPH and prostate cancer?
Oh, yeah. Very lovely question. Lovely question. Shall I answer now? Yeah. See,
Yeah.
yeah. So chat box, they have asked, sir, how do you identify difference between BPH and prostate cancer? Oh, good. So see, there are a lot many tests to know this. So whenever you are treating a case of benign prostatic hypertrophy, you must be quite clear and aware that this could be because of CA prostate also. So in carcinoma prostate, you have to will have a hematuria. This is one of the symptoms. It could be, and then they may have a bony pain if there are any metastases. And then when you do distal rectal examination, there will be a hard nodule will be felt. And in biopsy, you will get a positive result. More than anything, you always do a screening in which prostate specific antigen, that is PSA, will be high. So this is how you differentiate between benign prostatic hypertrophy and a CA prostate. That is clinical symptomatology, second distal rectal examination, and sonography for upper tracts, and then heterogeneity of the prostate, biopsy, and above all this, just a screening PSA will help you to know the difference between BPH and CA prostate. Hope I have cleared the question. Okay.
Sir, there is one question in the chat box. Doctor, sometime it is a confusion of symptoms of BPH and OAB.
Sir, yeah. 1 minute. Sir, how do I identify difference between BPH and prostate cancer? Doctor, sometimes it is confusion of symptoms, BPH and OAB. Yeah. When to refer to urologist? Ankit Raghav. Good evening, sir. Good evening, Ankit Raghav. Yes, thank you, sir, for okay. See, you have an overactive bladder. Overactive bladder is a diagnosis which has to be made after ruling out all other causes. So if you have a benign prostatic hypertrophy and overactive bladder, then don't consider it as a OAB. OAB is a diagnosis made by exclusion of everything. So they cannot be combined because it can be a symptomatology of BPH, but then overactive bladder is all investigations other than the symptoms are normal. So overactive bladder cannot be combined. There's one way to make it out, but there is no overlapping as such. Okay. So thank you for the right question, but you must be aware that these can be combined. These symptoms can be there.
Sir, there is another question in the chat box.
Okay, I'll just check. Tanvir Sangul, thank you very much. Yeah, Chandrasekhar, thank you, sir, for elaborate information. Good. Yeah, there is any question? No, I think I have answered.
Yes, sir. It is a Kenneth Crispin to when to refer to urologist.
Oh, yeah. When to, yeah, there was one. Yes, I saw that. When to refer to urologist. Yes. See, most of the cases can be managed at the physician levels. And then reference to urologist is required when the symptoms are bothersome. One, when your required treatment is whatever regular pattern of treatment, what you're giving is not giving the results. And then any of the positive PSA comes indefinite or inconclusive. And if the size of the prostate and then the quality of life is not improved, then probably he will require to be sent to a urologist. And as you all know that if there is a surgical intervention, like I said, any complications that are happening, recurrent urinary tract infection, a stone formation, or going on for malignancy, or retention, or chronic retention, or upper tract changes, these all things, I think at this juncture, probably it may not be managed at the physician level or a general practitioner level. then maybe he needs to be referred to a urologist. Thank you for the good question. Yeah.
So, sir, there are no questions left in the chat box.
Oh,
So, with
lovely.
your permission, would we conclude this webinar?
Yes, yes. Thank
Okay,
you.
thank
Thank
you,
you.
sir.
Thank you for the little problems in the initial starting. But anyway, you get used to it. I learned how to add my content next time. Okay.
Okay, sir. Thank you. On the
Thank you.
behalf of organizer, I would like to thank you for your informative and educative talk, sir. Thank you.
Thank you. Bye.